going to focus, that should go for, because your TB, you form a wall around it, and that's it. That's why it's so linked with HIV. Why? In HIV, you have decreased white cell count, CD4 count. If you have decrease of that, they break. They say, you know what, I need to go to the rest of the body to help out, so they end up breaking this wall. Now it makes sense, isn't it? Yeah. Thank you. So now the TB is out and makes the problem. That's why I said I'll give you one picture. TB has white cell wall around it. Whenever you have HIV, white cell goes down, they go outside to fight, and then now TB comes out. That's why TB and HIV, they link together. Remember HIV, the other one, dry cough, okay, with HIV, the other one, okay? So, I don't have to say any more. Go and focus and your HIV linking with TB. TB, obviously the symptoms that everyone should know, night sweat, weight loss, okay? People forget, remember everything, they don't remember the base, weight loss, okay? So weight loss, fatigue, short breath, hemoptysis, okay? Again, when you see hemoptysis, yeah, like I said, pleuritic chest pain, if you see hemoptysis, check again for PE, okay? I know, obviously, if this is basic and if it's everything pointing towards TB, that's fine. But I'm saying those keywords are there for just for PE. They usually leave it for them. Hemoptysis, pleuritic chest pain. Okay. Okay. Now, TB, the bacteria likes upper portion of your lungs. Okay. So when you X-ray, you see in the upper zone. So TB, first they ask you an exam for chest respiratory for you to diagnose it. Then there might be a question, anything to do with HIV. And the third thing is, how do you know it's a TB? So sputum culture, in here people get it wrong because look at the question. If they're asking you to culture, then it's Lowenstein-Jensen is the culture, okay? If they're trying to find the TB itself, you're using a staining, that's when Zell-Nielsen staining comes up. So culturing is different. If you want to find out if it's a TB or not, staining then is ZN, Zell-Nielsen staining. Okay? And obviously, if that's not there, look for acid-fast bacilli. Obviously, that's very common. So Zell-Nielsen, acid-fast bacilli, Lowenstein-Jensen, that's the culture. Culture, staining different, remember them, and that's it. Management, if it comes up, okay. Initial phase, first 2 months, IPE plus rifampicin, memorize that, and then after 4 months, rifampicin plus isoniazid. So things like this, you might not memorize it, put it in the right here, put it in the wall. So you can remember that, okay. And obviously for TB, we know what kind of question, history of Asia, Africa, alcoholic, weight loss, you know, night sweat. All of that should give you TB already. Okay? Medicine's never going to change. They're always going to ask you the same, it's always the same investigation, same diagnosis, they're going to change the story. Africa to Asia to homeless. Okay? So if you know your stuff, you can't get it wrong. Again, guys, so you pick up the, train your eyes, HIV patient with productive cough, weight loss, think of TB. HIV patient with dry cough, think of Carini. Next one is lung cancer. You know that lung cancer is the most common cancer? Then is breast. Okay. Now, for lung cancer, again, it will give you enough evidence that it's a lung cancer. There are few things you need to know. So can you see the whole rest PDF, I'm making you few lines now. Okay, go home, those few lines. All right, this is not, we're doctors already, we don't have to understand them anymore because we know it. So lung cancer, what do you have to know? Bronchial carcinoma is most common. Okay, bronchial carcinoma is most common, first thing. Obviously associated with smoking. I told you, smoking, think of COPD, think of lung cancer. Asbestosis. Okay, asbestos is associated with mesothelioma. So these wording, again, they want you to think. If they put asbestosis, they want you to think of cancer, they want you to think of mesothelioma, which is a cancer anyway, and then want you to think of smoking. So asbestosis links to smoking, mesothelioma. Obviously, there's other risk factors for bronchial carcinoma. There's a next page we've given you for you to read. But out of those, we did say for reading, but there's one thing I'll tell you. Cancer, no smoking history, lung cancer is adenocarcinoma. Okay? Done enough questions on it. If you have done it, you will see it's adenocarcinoma. So people go for bronchial carcinoma, people go for lung cancer. They, in our answers, I've seen lung cancer, then I've seen adenocarcinoma. Go for adenocarcinoma. Okay?
Without smoking history.
Without smoking history. Can you see? So smoking history, then bronchial carcinoma, lung cancer, adenocarcinoma, non-smoking history. Okay. Now, bronchial carcinoma, there's a few other things that we need to know. What is it that comes up in exam? Is that something that you might forget tomorrow or even today, end of the day? So that's something that needs to go in your ward. Is bronchial carcinoma, you have obviously squamous cell, smooth cell. For squamous cell, high Ca. Calcium is elevated. They ask you why. The reason, PTH. PTH goes up, high Ca. That's going to lead to confusion. Okay? You know, in a question, if they say a patient is confused, straight away you should go in your head few things. High Ca, low sodium, UTI, and Lilly. Easy, isn't it? Someone is confused, think of all of that, 4 of them, rule them out. Now, anyone with cancer, confused, check. Ca mentioned, high Ca. Small cell carcinoma, again, in bronchial carcinoma, gives you confusion because of low sodium. So when you have cancer, you have a high chance of confused in exam. Okay? Because you have low sodium, you have high Ca. Taking my time because remember, write them down. These are easy answers. So you don't want to get them wrong. You want to get them new questions or something that is very new, don't get the ones that is very easy. So these electrolyte imbalance. Adenocarcinoma in your third, remember non-smoking adenocarcinoma. And remember, what gives you the confusion? Low sodium, high Ca, UTI, LLE. Now, when you have bronchial carcinoma, right, most appropriate is CT chest. Imagine you go to a hospital and we think of the smoking history and everything that you have given me and so confusion and everything. We're not going to go for biopsy straight. What do? Order CT chest. So think of it like that. That's why they says most appropriate. In CT chest, if we find something, then we're like, okay, all right, 2-week referral, biopsy done. Or urgent biopsy done. Okay, that makes sense, isn't it? So think of it like that. Most appropriate will be CT chest. Biopsy is the definitive. That's it. Now you don't have to memorize it. CT chest, most of the chest stuff is CT chest anyway, and then to definitive is always a biopsy. And okay, another thing, yeah. You see in the questions, bone scan, very important. Lung cancer, they mets very fast. And they go to your bones and everything else. So if someone, anything to do with bone related, bone pain, anything, they need to do a bone scan if someone is established with a cancer already. You don't want to go bone scan before you establish the cancer. Establish the cancer and bone pain, then you need to go for a bone scan. Next page is mesothelioma. Obviously we know it's asbestosis. What else do you know? Pleura. Okay, pleura is the damage. Mesothelioma is a tumor of the mesothelial cells, so tumor of the pleura. So in exam you have to diagnose it. To diagnose it, what do you have to know? Is the ship building, railway engineering, and stuff like that. So those gives you indication that we're talking about mesothelioma. All right. Railway engineering, shipbuilding, shortness of breath, chest infection, chest pain, pleural effusion, weight loss. Weight loss should go straight to cancer, should go straight to TB. That's it. And when you go to cancer, you just have to go which cancer. Smoking, non-smoking, is working in an engineer, who is there, then that's it. Again, what's the initial investigation or most appropriate investigation is CT chest. What will you find in CT chest? Obviously, you can see your pleura, right? It will be thick pleura. That's it. So plus minus pleural effusion, because obviously you have a tumor if your mesothelial cells. Diagnostic is pleural biopsy. Obviously biopsy, but biopsy of what? Pleura, because mesothelia is your pleura that is affected. Treatment, write that down, it's not mentioned. Respond bad to chemo. There's a reason. Before I teach, I look at the questions, what they're asking me, and I teach you this. I don't teach you the PDF. So I've seen question, they respond bad to chemo. Okay, just learn that for the exam, for mesothelioma.
Respond back to
Bad. So they don't, it's not good. Chemo is not good for them. All right. Now, pleural effusion, that's another question came up. The mesothelioma can give you pleural effusion. If you see pleural effusion and if you go to treatment, thoracocentesis. Do you want pleural effusion? You want it out. All right. So pleural effusion plus minus. If it's present, then you know what the treatment is. You want to take the effusion out.
pleural effusion is pleural aspiration or something.
Yeah, thoracocentesis.
And they respond to bad to treatment means like chemotherapy. Radiation.
Chemotherapy is not good for mesothelioma. Okay, so these are exam questions, exam answers I'm telling you from. All right, so that's mesothelioma done. Think of the cancer, then go to the route that you want to go for.
And in mesothelioma, after they die, we have to refer the body for something, right?
Oh yes, yeah, corona, yeah. Because do you know why? They can get compensation and stuff like that. Exactly. Sarcoidosis is next. There's every topic, there's few things what you have to know. Sarcoidosis, what do you have to know? High calcium. Okay, straight away. High calcium. Afro-Caribbean. Afro-Caribbean, high calcium. Can you see the clinical features? There's no point even reading it. Everything in the lung will have cough, chest infection, dry cough, wheeze, shortness of breath. Everything will have shorter breath. So when you're reading, training your eyes, look for these things, right? Now, what's important in sarcoidosis? Afro-Caribbean, high Ca. What's the next thing important? Chest X-ray. So this is the third one we're talking about. Chest X-ray is important. Bilateral hilar lymphadenopathy. If you see the word bilateral hilar lymphadenopathy with high calcium, sarcoidosis. Do not waste your time. Next one is important for sarcoidosis. Don't get sarcoidosis wrong. I'm telling you all of the points that you have to know. Skin. Erythema nodosum. So you have redness in the skin. Which part of the skin? Shin. Okay, I'm giving you Afro-Caribbean, skin involved, chest X-ray, hilar lymphadenopathy, then it's sure. What's the next thing you have to know? High Ca, they're prone to kidney stone. Obviously high Ca. So question like this, they'll make it very long in exam. But you already know it after reading second line, where they're going. Okay, sarcoidosis, high Ca, Afro-Caribbean, skin involved, high, because of high Ca you have kidney stones. In your blood you have high Ca, you have high ACE. Now, ACE is the problem. Why? It's again monitoring purposes. Not for diagnostic, it's monitoring purposes. Okay, don't get that question wrong. And lung function test will show a restrictive pattern. Okay. Remember, there was two things we've said monitoring purposes today right now in the lecture. Earlier on, peak flow, and now this one, high ACE. Okay. Investigation, again, high CT, high resolution CT. And definitive, everyone gets that wrong as well. Remember, chest, anything definitive, it goes to biopsy. Transbronchial tissue biopsy. Okay. For mesothelioma, because it's coming from the pleura, it was a pleural biopsy. This one, transbronchial tissue biopsy. And initial one will be CT. So can you see in here, initial is none of them as chest X-ray. Chest X-ray will be there in your answer, in your question. Chest X-ray shows this, initial investigation, high CT, definitive biopsy. Easy, isn't it? And guess.
The high CT including sarcoidosis and bronchiectasis.
Bronchiectasis, yeah. And next one, Pancoast tumor. We're doing all the tumors. So Pancoast tumor is a tumor, usually squamous cell carcinoma. Sometimes it's good to know small or squamous. If you think it's important, put it in a wall. That's something you're going to forget, not something to understand. Pancoast tumor, location is important. You'll be right or left of the lung, and it will be top of the lung. So obviously you're going to get Horner syndrome. That's because your sympathetic nervous system is going down. And that's why you have sympathetic nervous system going down. That's why you have all the symptoms. That's it. This is understanding purposes. It's very easy. So you have, just for the video purposes, I know you guys know, pancreas tumor. So this is your lung. So you'll be there or there. Whichever side will be affected. Okay? Because why? This tumor here is pressing on your sympathetic. For example, vagus. Yeah? So it's very simple to understand. Okay, it typically spreads to nearby tissues such as ribs and vertebrae, and remember, top of the lungs. So if you have superior vena cava obstruction, what you can have? Facial swelling, yeah? Difficulty breathing, flushed appearance. If they're bending down, they feel like very hot flushing because obviously your SVC is obstructed, so you have backflow, and backflow gives you all the facial swelling and everything else. Okay, very easy. This is something is medical and pathophysio. If you understand it, it's very easy. So this obstruction give you the decreased sympathetic. So anything decreased sympathetic will give you your symptoms, and then you have your SVC obstruction will give you your facial swelling and everything else because of the backflow. Superior vena cava, remember the heart. So SVC is coming there, you're obstructed there, so backflow, jugular vein and everything else distended, and your facial swelling. And I've seen SVC patient just recently. So the patient came in with an A&E minors. So you can have, they just had a left arm pain. That's it. Left arm pain, and it ended up being this whole thing, SVC. Okay? SVC obstruction. So it's very important, guys. Just left arm pain, small symptoms they will come with, but it will end up with this. So if you know the symptoms very well for the exam, it's good. So left arm pain, facial swelling, okay, and shortness of breath, boom, straight there. Horner syndromes, any of those symptoms, go straight there. All right, next is, there's a picture for you to remember, and can you see this picture? And you can see the pancreas tumor right at the top. MRI is the imaging of choice to assess the structure. Obviously, the first thing you will think of is the X-ray and then CT, and then for more of the best one is MRI. Surgical is the treatment because we need to get rid of it. And that's the end of all the tumors and cancers done. So we've done asthma, tumor, cancers, all the pneumonia is done, so nearly done. Now we're with PE. Pulmonary embolism. Again, is very easy. You just have to know the treatment very well and diagnosis very well. Okay. All of us we know it from our clinical knowledge. The risk factors is obesity. That's something that is hard. So previous VTE, previous any clots or anything like that. Malignancy, very important. Even though PE, everyone knows it, we still make mistake. HRT, don't forget. HRT. COCP, don't forget. So even we don't even give COCP to a lot of even people with polycystic ovarian syndromes. They can't give them COCP, even though that's the treatment, because of the family history of PE. That's another obs and gynae question I'm telling you about. Okay, so stuff like that. So COCP, HRT, pregnancy, all of that should give you that. So look at the symptoms. Shortness of breath. That's not very specific. It isn't everywhere. But shortness of breath, chest pain, pleuritic chest pain. Tachypnea, tachycardia, hemoptysis is very non-specific. But if you can, do you remember what I told you? Chest pain, pleuritic chest pain, think of PE in your back of your head. Hemoptysis, think of PE back of your head. Okay. Now, your well scored, did you find it? No?
After the pneumonia.
Okay. All right. So PE is well score is very important. Why do you think the well score is very important? Because we need to know if we need to go D-dimer route. Now, in exam purposes, they want you to be more safe to go for CTPA. But if the score is very low and is not very suspicious, But like for example, that patient that came in with pleuritic chest pain for pneumonia can have pleuritic chest pain, right? Suspicion is very low, isn't it? So those patient is there for go for D-dimer. To make your life easy, so we don't make mistake, that's why there's a well score. You do the well score, you ask few questions and look at the answer. If patient is scoring 0 to 1, they're low risk, 2 to 6 is intermediate risk, 7 above is high risk. This again goes to trust protocol. Some people trust protocol, if it's more than 4, then don't go to CTPA. If it's less than 4, go to D-dimers, this and that. That's for trust policy. For exam purposes, remember, moderate risk, CTPA. High risk, obviously CTPA. High risk, if they're unstable, they need to go somewhere else, resus. But I'm saying moderate risk, and you have few symptoms, goes to CTPA, okay? Because obviously, in exam, they might give you well score this, but they won't give you this table. So what do you have is your brain, and I'm telling you now. Moderate risk, high risk, CTPA. Why not D-dimer? But obviously, just to let you guys know, everyone knows that D-dimer can be elevated in a lot of things. Yeah, infection, heart failure, you have pregnancy, so many things D-dimer will be, so it's non-specific. CTPA is diagnostic. Okay. Treatment, obviously we're going to go for low molecular heparin or fondaparinux is given, that fondaparinux is given a subcut. If patient's eGFR is low, remember that comes up in exam, guys, so patient focus on here. If the kidney function is not good, eGFR, forget that. If the kidney function is very bad and they can read as a chronic kidney disease or anything like that, you need to give unfractionated heparin. That's infusion that runs, because so if you have kidney is not working, that's when you give heparin. So that's one of the type of question in PE they ask you. Now, if you start in warfarin, the next part they ask you is bridging. Okay, bridging INR target should be 2 to 3. You give warfarin and your tinzaparin same time, because obviously warfarin takes 5 days to work. That's why once INR becomes 2 to 3, then you stop your heparin, continue with warfarin. That's what bridging means. Okay, that comes up in exam again. Heparin infusion comes up in exam, CTPA comes up in exam, and bridging comes up in exam. If they're asking you about D-dimer, it will be very, very low risk. Okay. DOACs is something that we use now in hospital. Who's going to use warfarin is very hard. You have to keep on checking the INRs. So DOAC is like rivaroxaban and stuff like that. So we give rivaroxaban and stuff instead of giving warfarin. They're going to start bringing up question on rivaroxaban and stuff like that. That's instead of warfarin, because warfarin is hard to manage. So patient with active cancer, if they have PE DVT, they need to continue the low molecular weight heparin. Why did I just say that? Because patient with active cancer, you can't give anything else. You want them to continue with low molecular weight heparin. In pregnancy, warfarin is contraindicated. Remember that. Pregnancy, warfarin is contraindicated. Remember that. They need to be on low molecular weight heparin, which is tinzaparin. They might say that word in tinzaparin in the exam. So that's low molecular weight heparin for PE, DVT. So if someone's pregnant, look at the question. You can't give that. Fat embolism. After long bone fracture, patient will have confusion. They will have rash. That will give you that's another PE. So all of these are actually exam points. Yeah. Before surgery, patient will need to stop warfarin and start low molecular weight heparin. You can't go to a surgery with warfarin, remember that, yeah? Low molecular weight heparin. How long before? 5 days before the surgery. Question in exam, pregnancy, what do I do? VQ mismatch or CTPA? I've written it there, CTPA. Don't argue, CTPA. High resolution, another thing is, there's a lot of debate on here, high resolution CT is not CTPA, it's just high resolution CT is high resolution of CT, CTPA. Okay. So obviously, like I said, well score is there, but you can't memorize it. If you think it's highly suspicious, go for CTPA as the. If you don't think it's PE, okay, that's fine. The next page, in exam, if it's PE, okay. Now, high risk PE, okay? Every trust, they have their own guidelines, but high risk PE and the patient is unstable. What do? Shock, hypotensive, you're going to go for thrombolysis. Because obviously the patient is unstable, right? There might be a massive clot. We can't wait for tinzaparin and bridging and everything else. So hypotensive, you have shock, so the patient is unstable, thrombolysis. Unfractionated heparin. So remember, patient now unstable, below 90, the systolic, you are seeing you are hypotensive, shock, heart rate is elevated, thrombolysis. Yeah, that's another exam question I'm giving you. So KNP, we've covered all the controversial questions. We've done. I've taught you. I've told you in pregnancy. I even said to you in active cancer, stick to low molecular weight heparin. That comes up in exam. Before surgery, stop warfarin. DVT, same thing. Obviously, deep vein thrombosis. We have a well score for DVT. Okay. So in DVT, we have a route to go: D-dimer or ultrasound of the leg. Okay, that's it. The other one was D-dimer or CTPA. This one D-dimer or Doppler ultrasound. Again, you do your well score. If it's very, very low, then and with D-dimer, with DVT anyway, you're just going to do a D-dimer. If it's positive, then you'll do ultrasound to confirm it, and then you start the treatment. That's the normal procedure. If DVT is suspected, DVT well score is above 2, start the low molecular weight heparin, arrange the Doppler ultrasound, which can be tomorrow. If it's out of hours, it can be tomorrow. If it's in hours, you can do it today. Does that make sense? Or let me repeat that. If DVT is suspected and DVT well score more than 2, yeah, then you know, oh, it's DVT, start. You start your low molecular weight heparin, which we do tinzaparin, anything. And then the patient can go home, come back for an ultrasound tomorrow if it's after out of hours, meaning after 5 p.m. Or they can, if it's ultrasound, they can do it today. They do it to verify. But they go home with tinzaparin. They go home with low molecular weight heparin. That's the normal procedure. If DVT is suspected, well score is less than 2. So you have a scoring to. Why do we do scoring? Because everything is subjective, isn't it? So scoring will give you a standardized thing. So score is less than 2 and you're thinking of DVT, then you're doing D-dimer. Then if your D-dimer is positive, then you start then you do your ultrasound and everything else. Okay?
So we do well score in DVT and PE in both.
Sorry, well score, yeah. So well score for DVT, there's well score for PE. Okay, so if you suspect DVT, choose Doppler ultrasound in investigation. If you think it's really a PE, then choose CTPA in examination. In exam, learn Baker's cyst because that is usually there when it comes to DVTs. Don't get confused with Baker's cyst. Baker's cyst is a cyst. So that's going to be your differential when it comes to deep vein thrombosis. And remember, if your patient's EGFR is less than 30, they don't might even tell you EGFR, they might say just kidney. If his kidney is bad, heparin infusion is your answer. Unfractionated heparin. Okay, and that's done with RESP.
So next is ABG. Yes.
Yeah. What's your question? What was it? What? Did you check it was working and everything? It's good. Is it good enough? Did you press it? Should press it?
ABG, continue.
Oh.
Okay, guys, so going to move to ABGs. So the question was low molecular weight heparin. Yes, it's always given subcutaneously. But your unfractionated heparin is going to be IV. It's going to be IV. Yeah. But you always give that when the patient has a poor kidney function. Okay. So we're going to go do a topic on ABG. That's the last section. Arterial blood gas. Right. So that shouldn't take too long. And we'll do questions towards the end. So the key thing to understand for ABG is basically the pH. So obviously, I'm going to talk in baby language. I know you're all doctors, just for us to understand. Okay. So pH, so 7.35 to 7.45. Now, whatever values you learn lab values, don't memorize them. You need to use the lab values GMC gives you. Okay, certain things like pH, they will not change it. Okay, given said that, you still cross-check with the lab values they have given you. Don't assume it's the one that you're thinking about. Always check cross-check with their lab values they have given you. But this should be standard, 7.35 to 7.45. That's the blood pH. So this is the range. Second thing we need to know, PCO2. Okay, so what does P mean? Partial pressure of carbon dioxide, and that value is important. And again, you need to use the values given by GMC, and don't try to memorize this value. Okay, so PCO2, carbon dioxide, and then you have bicarbonate, HCO3, and again that has a normal range, 22, 26. Again, use the values given by GMC. That's the values here. So very, very simple. Okay, so anything below this is acidosis, anything above this is alkalosis, anything within the range, that's normal. Is that okay so far, yeah? Okay. Now, one thing to understand is this. You see, H plus, this is acid. This is a proton, okay, with no electrons, only a positive charge. This is an acid, okay. And HCO3, this is alkali, okay. So if you increase the protons, it'll become more acidic. And if you increase the bicarb, it'll become more alkaline, okay. Then you need to think reverse. If you sort of decrease the acid, it becomes more alkali. And if you decrease the bicarb, it becomes more acid. If you understand this, then it's very simple. This is all of ABG. So my main focus is going to be on this proton. So you see carbon dioxide, okay? Carbon dioxide, CO2. So carbon dioxide, what happened, as you can see here, in the blood, it combined with H2O. You don't need to learn this for the exam, just to understand purposes. It mixes with H2O, right? And look at this reaction. It ends up making a proton. So carbon dioxide leads to acid. So therefore, if you increase your carbon dioxide, it means you are increasing your proton, okay? So if you sort of hold your breath, that means carbon dioxide is increasing within you. So your acid is developing even more. So your blood is becoming more acidic. So if you learn this principle, everything else becomes very simple. Second thing you need to know is very simple. Carbon dioxide, you breathe it out, isn't it? So it's going to be respiratory. And the other one, metabolic. So if you learn one, the other one is opposite. So this is going to be respiratory. Anything to do with the carbon dioxide is respiratory. Anything to do with this one is going to be metabolic. Okay. Second thing is this. Next thing is going to be compensation. What does it mean by compensation? You see, when you have acidic blood or alkaline blood, your body will try to restore it. Do some sort of feedback mechanism to restore it. That's called compensation. Sometimes it's fully restored. That's called complete compensation. Sometimes it tries itself, but it's not fully restored. Incomplete compensation. So once we do question, you'll understand this a bit more. So very important thing is carbon dioxide is respiratory, bicarb is metabolic. So compensation, I mentioned to you, is the way the body responds to this, try to make it back to normal, and that's called compensation. You have incomplete, complete, and it'll be very, very straightforward once we do some questions. Okay, so this is going to be a question, and I'm going to rub this off, okay. So actually I'll keep this. So let's do this question here. So now this patient here has a pH of 7.50. So in the exam, what you're going to do, you're going to check the reference, is it high, low, or normal? So this is going to be in the above range, so more than 7.45. So we're thinking of more of alkali, isn't it? Yeah. So it's going to be alkali. That's our first thing. So in the answer option, anything that has acidosis is out. It's always alkali. Now what's causing it? Is it the lungs or metabolic? So you see the carbon dioxide is actually low. So CO2 is low. So we said if CO2 is high, that means you have high acid. Yeah, that means if CO2 is low, you're going to have low acid. And we said here, if you have low protons, low acid, it means it's becoming more alkali. So therefore, we think that your lungs is contributing to this alkali condition. But let's fully check. Let's check the bicarb. Bicarb is 23, within the normal range. So therefore, it has to be the respiratory condition causing you to have alkalosis. So CO2 is low, so you have low acid, so it's alkali. So respiratory alkalosis will be the answer. Make sense? Now in here, let's do other things as well. You see, the body tries to restore itself back to normal. So is the pH normal or abnormal? The pH is abnormal. So there is no compensation. The question is it at least incomplete compensation? So no compensation means that the pH is not normal. Now, there could be one chance that it's trying to compensate, but it hasn't done it yet. So is it trying to compensate? So for example, in here we see that the patient has low CO2. Okay, so it's causing alkalosis. So what's going to happen? The other organ is the metabolic, the bicarb. The bicarb is going to do something, HCO3. The bicarb will do something to restore it. So the bicarb needs to do something to make it more acidic. Do we agree? Yeah, this is already alkali. The bicarb will do something so the blood becomes a bit more acidic to balance it, to neutralize it. Okay, so the bicarb, we said that if it's high, it's alkali. If it's low, it's acidic. So the bicarb should go low, meaning low, lower than this normal range. So the normal range we said is 22 to 26. Bicarb here is 23, within the normal range. So it is not trying to compensate at all. So therefore, full answer is going to be respiratory alkalosis with no compensation at all. Make sense? Okay, we'll do another example. This one here, okay. So the pH is 7.50, so it's towards the alkali, it's abnormal, 7.50. And straight away you can think to yourself, there is no complete compensation because it's abnormal pH. So what's causing the alkali? The PCO2, the carbon dioxide, is actually high. Okay, so the carbon dioxide is high, so obviously if it's high there, so it's making more acid. But that doesn't explain. Carbon dioxide is high, alkali, that can't be the cause of alkali.
Carbon dioxide within the range.
Within the range, thank you. Yes, it's within the range. So let's rephrase it, sorry. So carbon dioxide is actually within the range, okay? So in here, carbon dioxide, again, so if CO2 is within the range, so that will not explain this alkalosis. Bicarb here is 46. So bicarb is high, so this is causing metabolic alkalosis. There is no compensation, but let's say, is it at least incomplete compensation? So if we have metabolic alkalosis, our CO2 should go high or low? It's metabolic alkalosis. High CO2 means more acid, yeah? So we have already alkalosis, the body should make more acid. So the CO2 should be more than the normal range, but it's in normal range there. So therefore there is no at all, no incomplete, nothing. There is no compensation at all. So it's respiratory alkalosis with no compensation. Next example. In here, the pH is again very high. So it is alkalosis. PCO2, carbon dioxide, is 3.2. So the carbon dioxide is low, 3.2. And this, obviously, low carbon dioxide means there's less acid, right? So that can explain it, yes. So maybe it's a respiratory alkalosis. Let's see if there is any compensation. Obviously, pH is already abnormal, so it's not complete at all. Let's see if it's partial compensation at least. Bicarb is within the normal range. So there is no compensation at all. Incomplete or complete, nothing like that. There's no compensation. The body has not yet done anything to compensate. Answer is respiratory alkalosis with no compensation. Another one here. pH again high. So alkalosis. Carbon dioxide normal. So that doesn't explain it. Bicarb is high. I think this is the same question. It's the same question, isn't it? Yeah.